Welcome everybody, and thanks for coming along to this session on assisted suicide and euthanasia.
I want to cover quite a lot of ground. It's a bit ambitious, but we will see how we go. Probably seen things in the news over the last few weeks, and even yesterday there was something on Morning Report and that type of thing. So this is extremely topical and important.
To set the scene for our discussion tonight, I'm going to play a short introductory clip from Atul Gawanda.
One of the reasons I write is it gives me my chance to dive into problems that I'm very confused about. I've written about, what are we supposed to do about the cost of healthcare? Why is the malpractice system so crazy and what's the way it should be? I've written about why do we itch? If it's confusing and interesting to me, writing is my way of diving in and figuring out what to at least think about it. And this was one of the big ones. The two big unfixables are aging and dying. You can't fix those. We're afraid of talking to the patient about these problems as well. A lot of doctors feel like, I know how to have this conversation. I know exactly what I'm doing. But what I could see over and over again was that we weren't particularly good at handling people going through the last phase of their life.
And that's our topic. Not just the last days of life, but in particular in relation to that. We have an ageing population in New Zealand, like most Western economies, and this is going to be a growing issue in the years that lie ahead. Some of you will have seen the news, the rather sad case of Lucretia Seals, who had a serious brain tumour and has subsequently died of that. But she went to the High Court requesting that her GP be allowed to assist her to die without prosecution, should things come to that. So, although she didn't obtain the outcomes she sought, said Justice Collins, she has selflessly provided a forum to clarify important aspects of New Zealand law. And the judge touched, and just to highlight the difficulties here, he touched on the complex legal, philosophical, moral and clinical issues that are at stake here. It's not an easy issue, but we'll do our best. I thought I'd start off with defining terms. Some of you may know this, but Section 11 of the New Zealand Bill of Rights Act provides that everyone has the right to refuse to undergo any medical treatment. It's sometimes misunderstood, but you can, including food and drink, as it turns out. So no one can impose on you a course of medication or treatment against your will. Withdrawal of treatment when it is considered to be futile is not euthanasia. It's sometimes called passive euthanasia, but people who write and they say that's really unhelpful because it's not euthanasia, withdrawing treatment, and that is legal in New Zealand. Also, administering pain-relieving drugs where a foreseeable consequence is or could be the shortening of life is medically ethical and legal in New Zealand. It's all about intent, and we will come back to that briefly, but as long as you don't intend to kill the person, but you want to relieve pain, and it's a possible consequence of that their life will be shortened, that is acceptable. It's referred to as the double effect. The intent is to provide relief. A possible follow-on secondary consequence is that they might die earlier than they otherwise would have, but that also is not illegal. So the matters before us really are assisted suicide. This is the act of knowingly providing the means of death to another person at their request, usually with the intention of relieving intractable suffering in order that they can use that means to commit suicide. And euthanasia, similar in a way, but it's the act of intentionally, knowingly and directly causing the death of another person at their request with the intention of relieving intractable suffering. So if someone other than the person who dies actually performs the last act, then that is euthanasia. So injecting something lethal into somebody so that they die is euthanasia. If the person themselves takes the lethal medication, that is assisted suicide. Got that right, have I, Carol? Good. So that's our agenda, a bit ambitious, but I want to just do a very brief summary of the historical Christian view on this topic. Then I'd like to provide an overview of developments over the last decade, particularly in overseas jurisdictions, which provide some evidence and data of how this all works in practice. Then the modern day rationale for euthanasia and why legalisation in New Zealand is being pursued, and then a response and reply based primarily upon non-religious arguments. So the traditional Christian view. Others could probably do this better than me, but to give a brief historical snap, apparently St. Augustine was the first to talk about this issue in the city of God. Then in the Middle Ages, Thomas Aquinas argued that it is unlawful to kill oneself because of three main things. It contravenes our natural inclination to love ourselves, which is scriptural. Love your neighbour as you love yourself. Because it harms the community, and because it is for God alone to determine the times of our life and death. A lot of scriptures on this, but just a few. If you have a church background at all, you'll be familiar with this. God made humankind in his own image, and therefore human life must be treated as a sacred gift from God. We trust in God's providence and care as an overriding theme. The Lord gives, the Lord takes away, said Job. Blessed be the name of the Lord. My times are in your hands, said the psalmist. And on a similar theme, I was just reading it today actually, Psalm 139, all the days ordained for me were written in your book. Interesting thought, isn't it? We are not our own, we were bought with a price. So each of us should enter the dying process with all its mysteries, with trust in God, and in solidarity with our fellow humans. We should die with the dignity of letting ourselves be loved unconditionally by God and by others. And of course, the whole impetus of the gospel really is to bring compassion and help rather than to do harm. It intends new life in this world and hope for life in the world to come. However compassionately motivated, euthanasia, however, intends death. So you see the contrast. The gospel intends life and hope. Euthanasia intends death, which affects not only the person whose life is being terminated, but also friends, family, and others who know and love the person. And the gospel, of course, the gospel of Jesus Christ, does not make us immune from suffering, that's clear, but it does, or it should, bring grace and hope as a part of our human experience. That's it on the traditional Christian bit. I want to move right along, but I just want to play a little clip from Maggie Barry, sort of in the spirit of how Christians think about some of these issues. It's a little reflection on her dad as he came towards the end of his life. Maggie Barry, you probably know her, MP for Northland, has several ministerial responsibilities, including, I think, senior citizens, actually, and other things. So this is Maggie.
The closer they got to death, particularly in the case of my old man, my father, he'd fought in the war, he was a battler. He didn't want to die. He had last rites, we Catholics, 12 times. As I kept saying to him, Dad, look, if you want to go, you are the most blessed man in all of Wellington currently, and I'm sure that you'll be fine. The pearly gates will be open for you. But he was a guy who used to enjoy a drink and a cigarette, and lung cancer and skin cancer were the two things that got him in the end. But he didn't want to have morphine because he wanted to go to his maker with a clear head. And he was determined about that, really determined, and he was a stubborn fellow, and it took me quite a while. I'm an only child, and I got on very well with my dad, but it took me quite a while to persuade him that morphine is actually a very good drug when it's administered properly and by people who know what they're doing. And I personally believe, and others more knowledgeable than I will speak about the clinical side of it later, but there are very, very few people that need to experience the levels of pain and discomfort that the Marianne streets of this world would tell us is a part of death and something we need to avoid very carefully. So, the closer Dad got to death, the more he valued life. And I have seen that very often in friends of mine as well. When they're told they're dying, there's that grief, that anger, the various emotions that every individual has in their individual way. But it is very important, I feel, that we let them decide. Sometimes I think that euthanasia, if we change the law, is more for the living. It's more for the people who feel uncomfortable about witnessing the discomfort of others. And they're not in control, they don't know what to do, so they want to finish it quickly.
Okay, so that's Maggie. It's about a half-hour clip on YouTube. It's worth having a look at sometime, as she was addressing a conference on this topic a couple of years ago. I want to move now to sort of overseas developments and just rattle through some of these quickly. Firstly, Switzerland. Interesting case because, believe it or not, assisted suicide has been legal since prior to World War II in Switzerland. In their penal code, it says that every person who, for selfish reasons, incites or assists someone to commit suicide shall be sentenced to imprisonment of up to 5 years, or, curiously, a fine. But as long as it's not done for selfish reasons, it's legal. Euthanasia is still illegal in Switzerland, but assisted suicide is not. And technically no doctor needs to be involved either, although in practice they often are in terms of securing the necessary medications. And there also need be no medical condition in Switzerland. There are two agencies, Exit and Dignitas. You may have heard about them or read about them. They essentially provide an organised service. That's the only word you can use, actually. It's a suicide service. There are, of course, protocols around. I'm not saying that carelessly, but it is technically a service. Curiously, the government itself actively promotes palliative care and campaigns against suicide. They don't particularly like it, but any attempt to sort of adjust their penal code has apparently run into resistance. And, despite the fairly strict rules around how it works in practice, because of the unusual nature of the law, it's really up to Exit and to Dignitas to set their own criteria. And not that long ago, Exit very controversially expanded its criteria so that it now means that for elderly people who aren't terminally ill but simply wish to die as old age advances, Exit will assist. Okay, the USA. Doctors are allowed to prescribe lethal doses of medicine to terminally ill patients in 5 US states. Euthanasia in the US as a whole is illegal. In recent years, the aid in dying movement has made incremental gains, but the issue, of course, remains controversial, as you might have seen in the news. Really, the flagship state is Oregon. They were the first back in 1997, the Death with Dignity Act, and it allows for terminally ill, mentally competent patients with less than 6 months to live to request a prescription for life-ending medication, which they must take themselves. So there's the numbers. Oregon is roughly the same size as New Zealand in terms of population. So in one sense they're small, but you can see an increasing trend. The green line is the number of actual deaths. So it's gone from 16 when the law started to 105 as of last year. What's interesting is that more prescriptions are taken than are actually used, but it's a little bit hard to measure because, again, curiously in Oregon, once it's been dispensed, approved and dispensed, it's not tracked. And there are instances where people may take the medication as long as 2 or 3 years after it was issued. I put this in as a bit of a side one, that people sometimes say, well, if we can legalise assisted suicide and euthanasia, maybe it will lower the general suicide rate in the population. The evidence doesn't support that. In Oregon, their suicide rate runs higher than the national average, and also in Holland, the general, for want of a better term, underlying suicide rate has actually gone up slightly as well during the time that it's been legalised. So it doesn't seem to have that particular benefit, if you want to characterise it that way. To give a balanced view, I think with all the publicity we see that there's a kind of a sense created that, oh, it's just inevitable, over time it'll happen. But actually that's not true. In the US over 20 years, there's been more than 140, it's a lot, legislative proposals across 30 states. So apart from Vermont, which did legalise assisted suicide 2 years ago, all bills that are not currently pending, because there are some in the hopper, so to speak, were either defeated, tabled for the session, or withdrawn. And in Massachusetts, for instance, there was a debate about this, and they defeated the proposed Death with Dignity Act in 2012. And I saw in the news just last week, you might have heard that in California, they're attempting to legalise assisted suicide. Couldn't get the numbers in committee, and so basically it's been shelved for now, and possibly will be reintroduced next year. So people are pushing back, and it's certainly not a done deal. Belgium, I won't read all of that. They basically legalised in 2002, and there's some criteria there. I can give you the slides later for anyone who's interested. But again, there's been a reasonable growth. It started at 235 cases in 2003, and that grew to 1,807 in 2013. Controversially, for obvious reasons, last year they became the first country in the world to legalise euthanasia for children, so essentially no age limit. The child must be conscious of their decision, terminally ill, close to death, and suffering beyond medical help. They also need the assent of their parents to end their lives. So, this is a sad one. I felt very sad. A healthy 24-year-old has just been granted the right to terminate her own life because she has suffered from suicidal thoughts. Amazing, isn't it? Apparently over a long time, but there you go. And Holland. probably the one that gets the higher profile. The Dutch situation is unusual in some respects because the present law developed out of a long-standing acceptance of euthanasia, including among medical practitioners. I wouldn't say it's unique in the world, but it's not the typical country for some reason in that respect. Anyway, they legalised euthanasia and assisted suicide 14 years ago, 12 years ago. They did impose a strict set of conditions. I won't read them out, because one of the issues is the criteria over time have been loosened. And that's one of the issues that I want to touch on. The legislation, of course, has provoked a fierce debate over the right to suicide. Again, curiously, in Holland, it's legal, but only under certain conditions. So there's quite a vibrant right to life movement, even in the Netherlands. Isn't that strange? That tells us something, and we'll come back to that. There's the trend in the Netherlands. They're about 4 times the size of New Zealand. So on an equivalency basis, that would be running at about 12 to 1,300 New Zealanders a year, just to give you some sense of scale. So that's still a small proportion of all deaths in the country, but in its own right, it's a non-trivial amount. Now, there's a blue and a green. I haven't done it for all the years, ran out of time. Which do you think is euthanasia and which do you think is assisted suicide? Euthanasia is the blue. Yeah, it's mostly euthanasia in Holland by lethal injection. I'm going to come back to this issue, but three years ago a clinic was opened. They call it, a little bit euphemistically, euthanasia on wheels. They'll go to your home. And that was introduced because they have this arrangement of a close relationship between the patient and the GP. And the GP has to agree with the patient that it's justifiable. And they don't always, for quite legitimate reasons in their view. Some people are not happy with that, and some GPs weren't happy with that. So they opened this clinic in The Hague, and they now have about 200 people a year that they essentially offer an out service to. But I thought this kind of cover from Newsweek said it for me back in February, because there's an issue here that we'll come back to, a kind of an ethos or a culture that can develop around this if you're not. It's just a benign acceptance that this is just the way things are. So the headline said, the Dutch are choosing euthanasia if they're tired of living, others may soon follow. So the point is just, that's sort of how Holland is being characterised. And so in some ways it has become a flagship for some of the advocates in other parts of the world. I will keep alluding to this. I call it criteria creep. And it's happening in Holland as well. I just want to play this clip, which is self-explanatory and may surprise you.
Let's move to the Netherlands. Doctors in the Netherlands are calling for the country to give terminally ill children the right to die. Euthanasia is legal in the Netherlands for anyone over the age of 12, but the Dutch Pediatric Association says it's time to do away with the age limit altogether and act on a case-by-case basis. Should the Netherlands decide to change its law, it would be only the second country, alongside Belgium, to allow euthanasia for young children. Joining me now is a member of the Ethics Committee of the Dutch Pediatric Association, Edward Verhagen. Welcome.
Yep, thank you.
You support the effort to get rid of the age limit for euthanasia. Some find that unsettling. What's your position and why?
Well, currently, as you may know, the age limit for euthanasia in Holland is 12 years. What we're basically saying is that it doesn't make sense taking an age limit or a calendar limit as a deciding moment for competency. We would rather take a case-to-case assessment of competency instead of the calendar age. So basically that's the point. And there's another thing that we've brought forward, and that is that we have a regulation for babies, for newborn euthanasia. So the second statement that we made last week is that we should be considering looking into euthanasia for 1 to 12-year-olds, because we have a regulation for 12-year and older, and we have a regulation for newborns. And why is it that we haven't yet come to regulate practice for unbearable suffering in the age group 1 to 12 years.
So yeah, you did hear that right. They, in 2004, legalised euthanasia in the first 12 months of life. In very extreme cases, I have to say. I mean, I don't want to say that this is happening here, there and everywhere. It's not. It's very tightly controlled. But nonetheless, it's consistent with the general approach to these sorts of issues in the country. This is a very kind of heart-wrenching story in a way of a woman called The Last Days of Annie Buss. And we don't have time to go through it, but I chose it because it talks a little bit about the clinic that I mentioned, based out of The Hague, and it highlights, in a sense, where things have currently moved in the Netherlands situation. They tend to take on the more controversial ones anyway, and so the question is raised, if a society legalises assisted suicide, what are its limits? Among the patients here was a woman with a pathological fear of grime and bacteria who had a washing obsession. I mean, in one sense, it would be slightly amusing if it wasn't so serious, the context of it. And also a 63-year-old man who feared loneliness after his retirement. So in both instances, doctors here helped the patient to die. Okay, so that's the overseas jurisdiction, a bit of a whistle-stop tour, but it gives you an idea of the international context. All right, so the rationale for euthanasia and physician-assisted suicide. And I'm relying here on, to give us a bit of a simple framework, principles of biomedical ethics. There are 4 of them, but there are 2 that are really drawn upon in supporting the argument for both of these practices are autonomy, to act in such a way as to give due regard to the patient's own wishes, and beneficence, to act for the patient's good. Okay, so let's have a look at these. Autonomy, respect for a person's wish to die in a manner of their own choosing. Well, the statement goes that it's my life, and what right do you have to tell me what I can do with it? The state does not own my body, I do. So it's argued that individuals, of course, have the right to make their own decisions about healthcare, are best qualified to make quality of life assessments for themselves based on their own experiences of life. People basically want control over their choices. And in liberal democracies, this is not a surprise. A paramount value is indeed that the individual has the right to make his or her own life choices to determine his or her future. So the strength of this value has almost certainly increased, I think, as we've become more individualistic as a society. And so this right of life choice includes the right of a citizen to decide that he or she has no future, or no future that they want to live out for themselves. People ought to be able to make what Marion Street's private members bill called the end-of-life choice. Okay, let's have a look at beneficence. To relieve suffering and to minimise harm. The physical suffering can and sometimes does occur through the process of dying, can be avoided or at least reduced, so the argument goes, where assisted death is used. And of course, nobody likes the thought of anyone, let alone a loved one, enduring severe pain. These are weighty issues, aren't they? Particularly in instances where they have a terminal illness with little or no prospect of recovery. Probably the main reason that most people advance in support of legalising assisted suicide and euthanasia is indeed compassion. And sitting behind this may also be a level of fear about the unknown in relation to death and dying, particularly when a friend or a loved one is suddenly confronted with that possibility. Now, it's so important, and at the risk of stating the obvious, I do want to make the point immediately that assisted suicide and euthanasia are not the only means of relieving physical pain. Pain management, of course, has been for a long time an integral part of good medical care at all stages of life, and the modern hospice movement established by Dame, I never get the name, Cicely, is it, Damaris? Cicely, thank you. Dame Cicely Saunders, back in 1967 in the UK, has led to the establishment of a whole new discipline and culture around palliative care. Saunders introduced the idea of total pain, which includes the physical, emotional, social and spiritual dimensions of distress, and I do want to come back to that a little bit later. Within the context of arguments in support of euthanasia, however, the point of debate is whether palliative care can alleviate extreme and unbearable pain in all instances, or whether a case might remain, in rare instances, so it's argued, for assisted suicide and euthanasia on compassionate grounds, and as I said, in exceptional cases. During the Lucretia Seals hearing, extensive evidence was presented to the court from clinicians with experience in treating patients in her circumstances. Her principal oncologist explained that usually it's possible to provide palliative relief to patients in her circumstances to reduce the effect of pain, nausea and seizures. The judge accepted that the development of palliative care medicine as a specialist branch of medicine and the establishment of hospices has greatly improved the clinical care of patients who are terminally ill. But there was professional disagreement, and if you've read the court ruling, you'll know this, over the extent to which palliative care can relieve distress in those with terminal illnesses. Okay, so we've been looking at the principles of biomedical ethics. We've looked briefly at autonomy, beneficence. On the other side of the equation, we also have to consider non-maleficence, the idea of acting so as to avoid harm to the patient, and justice, to act justly with respect both to the patient's own interests and to the relevant interests of others. Okay, well, a response in reply. Firstly, for those of you that didn't read the outcome, the recent Seals case has again clarified the law in New Zealand, and the judge concluded that there were no, although he was of course sympathetic to Ms. Seals' circumstances, there are no grounds legally for assisted suicide or euthanasia within New Zealand in any respect. The law generally is clear on that. There was some attempt to look at the Bill of Rights Act as to whether there may have been an opportunity to find some room to manoeuvre, but the judge ruled that in that respect also it did not support either of these practices. Okay, so autonomy. It's kind of a modern argument, really, as in, if you think of it in the context of history, it's only recently that humans have really felt in control of their destinies, to the extent that we tend to nowadays. We, for the most part, get to choose careers, marriage partners, what we do, where we live, in ways that our ancestors perhaps could never have imagined. So it seems reasonable to some to propose that we do extend this freedom of choice all the way to the end of our lives. But leaving aside the Christian idea that actually no, we're not intended to have that much control, I think it's important to observe for starters that in any society with two or more people, absolute autonomy or freedom is impossible. If you drove to this meeting, chances are you stopped at a red traffic light or a compulsory stop sign, or if you didn't, you should have. So, in a way, if you think about it, that represents an imposition on your freedom of movement. But it's for obvious reasons. It's part of a kind of a well-accepted social norm that balances your interests to get here as quickly as possible against the interests of everyone else getting wherever they want to go as quickly as possible. So if we put it more generally, we of course live interdependent lives to at least some extent, which therefore raises questions about where the lines between autonomy, the rights purely of the individual, and broader societal considerations should be drawn. Now, as I said, autonomy allows a right to die already in New Zealand in the sense that suicide per se is not illegal. And under the Bill of Rights Act, again, as I mentioned, you're fully entitled to refuse medical treatment and so on. But if you think about it, claiming a right to assistance in taking your own life means that it's not fully an autonomous act. By definition, it implicates at least one other or others in actively taking your life. So, to quote John Finnis, Professor of Law and Legal Philosophy, for over 20 years at Oxford and a Fellow of the British Academy, euthanasia is not a private act, but precisely an act in which you seek assistance from someone else, or which you are asking someone else to carry out, sharing your intent to destroy your personal life. So in that sense, it's no more a private act than a duel or an agreement to sell yourself into slavery that society would have something to say about. If there's a moral duty to die with assistance, then this logically implies a corresponding moral duty to kill. So on whom does that duty fall? you're asking for assistance. So if it's a moral duty, on whom does it fall? And actually, why are we so quick to insist that it rests with doctors? Well, I think there are reasons, but advocates of the legalisation tend almost invariably to wrap the issue in the language of medicine and healthcare, because it implies a professional stature and respectability, which to the average citizen means that it's ethically okay. There's a certain suspension of judgment, arguably, that occurs in those circumstances. So the Marion Street draft bill, which is not active at the moment, but I think it's the best we've got to talk to in terms of New Zealand possible intentions, in the preamble envisaged that the bill would fall under the portfolio of the Minister of Health. And part 2 was entitled Medically Assisted Death. So I think I'm making my point there. Slight different tack, audience engagement. I didn't have any New Zealand data for this, but Gallup, you've probably heard of the Gallup organisation, one of the most respected polling agencies in the world. So this is US data for starters. They ask people all sorts of interesting questions on all sorts of things. And from time to time, they ask a cross-section of Americans about the moral acceptability of certain issues. One of the questions they have asked is, what is the moral acceptability of suicide? Now, if you rate it to New Zealand, just think about that. How many, out of 100 New Zealanders, how many do you think would say suicide is morally acceptable? A minority? Yeah, that'd be a reasonable hunch, wouldn't it? Well, in the US situation, that's the data, 13 and 16%. You know, you can, one point of view, you can say this seems high, but on the other hand, it's obviously a minority, and in fact a relatively low minority. If you ask the identical question, but instead of saying how moral is suicide morally acceptable, in your opinion, you say, is doctor-assisted suicide morally acceptable in your opinion? Would it change? Why? Logically, it shouldn't. If suicide is morally unacceptable, then the fact that someone happens to help you in the process, why does that change the underlying morality? It's this doctor idea. I'll tell you the answer. I don't know if this will surprise you or not. It's essentially the identical question, but just prefaced by doctor-assisted. It's a marked shift, isn't it? You have to interpret this, but that's not just margin of error stuff, is it? There's something systematic there. I want to play a little clip from Margaret Somerville, who kind of develops the same idea a little bit more. This is her take on it.
Also, the other thing that happens is that when you put a medical cloak on something you do, you can often do things that you would never do if you didn't think you were doing something medical. Medicine dulls our moral intuitions when we use it as a cover. I mean, I had an example of this in the euthanasia context, that I was arguing against physician-assisted suicide or euthanasia given by a physician. And I said, you know, we can't have doctors killing people. And one of the doctors in the audience, who was very pro-euthanasia, jumped up and said, would you stop using that word killing? It's not killing, it's a merciful act of clinical care. Well, that sounds nice. We all want merciful acts of clinical care. And I think that's what happens in euthanasia, that we look at it as both merciful, we're getting a woman out of a bind, and clinical, medical, so therefore it must be okay because doctors don't do bad, unethical, illegal, well, not illegal, but bad, unethical, sort of morally wrong things. And later in this same speech, I talked about how somebody had suggested that if we were going to have euthanasia, it shouldn't be doctors because that terrified patients. They thought every time a doctor did something to them, they were possibly euthanizing them. And so this article suggested we should have a specially trained group of lawyers who would give lethal injections because lawyers know very strictly how to obey rules. And this same doctor jumped up in the audience and said, Margot, are you crazy? He said, you'd have lawyers killing people? And I said, just a moment. I said, what have you just said? I said, when it was doctors doing exactly the same thing, you objected to the word killing. When it was lawyers, you're saying to me I'd have lawyers killing people. So that's the medical cloak. It shifts our moral intuitions towards thinking that what we're doing is acceptable.
I would like to have drawn more on her stuff. I don't know if you spotted it. She has 10 honorary doctorates. The NZMA situation or position on this is very clear. It's opposed to both assisted suicide and euthanasia and says they are unethical. And again, as Tion just said, even if there's a law change in New Zealand, then the practice will continue to be unethical. That is their stance. Hospice New Zealand's also opposed to such a change. And just yesterday, Stephen Child, the person that Dion was just talking about, who's chair of the New Zealand Medical Association, was interviewed. Can't play the whole thing, but I just wanted to play one clip.
The official position of the Medical Association is that it's not ethical to help someone die. That's correct, isn't it?
Yes.
It's nothing to do with the illegality of it.
Yes.
When was it?
Irrespective of the legalities, it will remain unethical.
When was that last reviewed, and what is that decision based on?
This is, I think, the fourth time this has been a public debate in the last 15 years, and the NZMA has regularly discussed it within our board, our specialist council, our Doctors and Training Council, our GP Council, etc. So within the profession, this has been a discussion that has been reviewed many, many times. The World Medical Association has also reviewed its position, as has the Australian Medical Association, etc., around the world. So this is an issue that has been discussed, but has been a consistent stance really since a code of ethics 350 years ago.
Again, with Parliament's Health Select Committee holding an inquiry, should things change? I mean, who can say this far out, but should things change, should the legislation change in some way? Would the Medical Association need to revisit this?
We don't believe so, no. And I mean, we completely respect the rights of a patient autonomy, the patient to make their own decisions. And as an extension of that, therefore, we completely respect the right of society to have this debate, to have this discussion, and for Parliament to pass legislation as they see fit. But irrespective of the outcome of that legislation, we do not believe that it will be ethical for the medical profession to then participate. An analogy I sort of throw out is it's like you decide you want to rewire your bathroom and then you call a plumber. It's not the medical profession's responsibility, ethics, or part of our care or our training to participate in terminating life.
Okay, so pretty clear, isn't it? And also that's the view of the World Medical Association as well, with which New Zealand is affiliated. As I mentioned, Hospice New Zealand has a similar stance. You can look at it on the website. If autonomy, despite all of this, allows a fundamental right to die, then is it an unconditional right which trumps all other values and considerations? For instance, do you have to be terminally ill and or in severe pain or not? Does it apply to a depressed 16-year-old or not? What about the preferences of family and friends? Should that have a bearing or not? Or is any right to die, if indeed there is such a right, highly conditional and limited? And if so, where do those limits lie? As we can observe already in other jurisdictions, once the principle of allowing state-sanctioned killing is ceded at all, there is a slow but sure pressure to shift the boundaries of acceptability over time. It's almost inevitable, really on the grounds of discrimination. My neighbour can get it, and I sure feel bad. Why can't I? It's inexorable, I would argue. And the thing is, I mean, I'm not thinking about this for myself, but I think about, my grandkids, that, it might take a decade, it might take 2 decades, but once we open the door, in my view, you can simply not stop it opening wider and wider till you get to the Belgian situation of a 20-something-year-old, for, I think, quite sad reasons, being allowed to take their own life. And as I mentioned earlier, Holland still has an active right to die group. And I find that strange, I mean, in one sense. But I think it's a reflection of this inexorable push. Once the door is open, push it further and further apart. If the right to die is granted to some, then discrimination can easily be claimed by others, and so it goes. Giving undue weight to the principle of autonomy, in fact, leads readily to an argument that the 400 or more people in New Zealand who commit suicide each year are simply exercising their right of autonomy. I mean, you can mount that argument if you weight autonomy heavily enough. I don't, by the way, but I'm just making the point. If they've reached such a point of despair and hopelessness in their lives, that a number of them would say, if we had had a chance to talk to them, that they see no alternative but to take their own lives, then they're clearly suffering in some way or another. I think you can't not think that. They might as well say, or at least think, that they are in fact suffering from an irreversible physical or mental condition that, in their view, renders their life unbearable. They see no other way out. And yet there is clearly something within most, and I hope all of us, that at least to some extent, almost instinctively, just cries out, no, don't. It's not right. Please stay with us. You are a unique individual of value. Stay with us until your time properly comes. And the government does agree, I'm pleased to say, in New Zealand. 2 years ago, Prime Minister John Key launched a $25 million suicide action plan aimed at reducing the national average of 500 suicides a year, including, very sadly, about 100 youth suicides. He called it critically important to tackling New Zealand's high suicide rate, noting that the number of young people who took their own lives was, quote, far too high. I mean, he thought more about that. Any number above 0 is too high. There's also, I don't know if you saw in the latest budget, just a few weeks back, funding for Maori interventions, which is great, another $2.1 million specifically to deal with the Maori suicide rate, which is higher even than the national average for New Zealand. And, we see initiatives like this, a poster to prevent suicide. You might have seen them on bus stops or something. Actually, that's a bit hard to read. Be a friend, it saves lives, suicide prevention and so on. And as I was thinking about this, really for a bit of light relief, and then I decided, actually, it's not light relief. It could be true. Because that would be the situation, wouldn't it, if we legalised? Well, no, we don't want you to, but over here, it's okay. Exceptions apply. Yeah, I know. So, it's not actually funny, it's deadly serious in the worst sense of the word. Before I move on from this fundamental contradiction between suicide as an acknowledged social problem in New Zealand and the call to legalise assisted suicide, I'd like to note that the words I used to describe the potential state of mind of a suicidal person were taken almost verbatim from Marianne Street's end-of-life choice bill, which was withdrawn prior to the last election for political reasons. A qualifying person may receive medical assistance to end his or her life if he or she suffers from an irreversible physical or mental condition that, in the person's view, renders his or her life unbearable. It's actually quite a broad criterion. The other one was terminally ill, which you would expect. But this one, you can kind of see how this would play out if it was ever legalised in New Zealand. You could probably drive a bus through it in the end. I'd like to add that under the Dutch legislation, suffering must have a medical dimension, but there's no requirement that the medical condition should be serious or life-threatening. They accept that unbearable suffering is a subjective notion and that the patient's perception of the situation is part of what makes the suffering unbearable. Their official position is that multiple geriatric syndromes can cause unbearable suffering with no prospect of improvement, which actually sits in part behind a push towards assisted suicide and euthanasia on demand in Holland for those over 70. It's not legal yet, but there's quite a concerted push to try and bring it about. Okay, back to beneficence, acting out of compassion to relieve suffering and minimise harm. Probably the main reason for people supporting the idea of assisted suicide, as I said, is one of compassion. I think that's clear. None of us likes the idea of anyone suffering unnecessarily or to an extreme level. But on the evidence that we have from other countries, and this may or may not surprise you, it would seem that relatively few people are requesting assisted suicide or euthanasia, specifically because of physical pain. In the official Oregon stats, for example, only about 1 in 4 patients who have died from ingesting a lethal dose specifically reported inadequate pain control or concern about pain as a reason for the suicide. It's much more likely to be things like autonomy that we've already discussed, or being less able to engage in activities making life enjoyable. Even more worrying, a Dutch study showed that half of all people requesting euthanasia or physician-assisted suicide were clinically depressed. 50%. Isn't that staggering? Yeah. I mean, I found a couple of great articles on this, and I had quotes in and I took them out. I'm already pushing my limit a bit, but I can give you the references if you want. And it was very sad. They were saying we're responding in entirely the wrong way. We should be dealing with this as a case of depression, in that sense, and then see where that leads us. To quote a kind of a family friend called Talia, she's written a great blog on this. I'd be happy to give you the reference, actually. If you want a quick, concise summation of these issues, then read Talia's blog. The suffering that many people experience at the end of life is not the physical distress we often think of it as when talking about euthanasia, but existential distress. If someone without a terminal illness was similarly distressed about things like fear of death, regret, or depression, we would respond with treatment, not with euthanasia. I thought that was very nicely put. She reports on a Canadian study which found that rather than euthanasia, a very effective response to such requests, along with medical treatment of depression, of course, is what they call dignity therapy. It's a specialised psychotherapy where volunteers listen to and write down a person's life stories, then present them to the person to bequeath to their loved ones. And in talking to Damaris about this, she said at Taumanga, where she works as a palliative care nurse, they offer a whole range of services. I mean, what hospices offer is really quite remarkable. But they offer a great range of services, one of which is, it's not called dignity therapy, but they bring in someone called a biographer. And the idea is that they sit down with you, they take, it's kind of like scrapbooking or story, they just kind of listen and they write out your story. And again, Damaris says this is another kind of part of a holistic approach to treating people with care, respect and compassion and love in the final stages of their life. And in one of the studies that I came across, things like dignity therapy can halve the rate of requests for euthanasia. Significant, isn't it? It's not like it's just fiddling with the issue. It's a significant reduction. So in short, many people just need to be listened to and know that their lives have significance. Atul Gawande argues persuasively in his book that our ultimate goal is not a good death, but rather a good life to the very end. It's a nice way to put it. Assisted living, he says, is far harder than assisted death, but its possibilities are far greater as well. I really like that. Here's a short clip of him explaining the power of just listening to people in the closing stages of their lives.
The most reliable way to find out what people's priorities are is to ask them. Yes. And we don't ask. Less than a third of patients, so for example, in a cancer trial that looked at people who had on average only 4 months to live, less than a third of the patients did the doctors have a conversation saying, well, what are your fears and goals? What are your priorities if time becomes short and your health worsens? The ones who did have that conversation had less suffering. They stopped their therapy. If you have the conversation, you suffer less. Yeah, because people then often choose. They'll stop the chemotherapy earlier. They will end up spending less time in the hospital. They'll start hospice sooner. And the irony is, in subsequent studies that have been done, that they tended to live, in the case of lung cancer, for example, 25% longer by reaching that decision.
Interesting, eh? So there are alternatives. That's what I'm really trying to say. It's not like, oh, well, if we say no to this, we're being mean-spirited or sort of, Grinches that like to steal Christmas. There are alternatives to these difficult issues that we should consider. When we encounter someone near the end of their life who is distressed in any way, we need to respond as a society, or as a group, or as friends, or as a church, with friendship and good medical care rather than euthanasia. There are alternatives. Now, this raises some bigger questions about, are we prepared to put our money where our mouth is, actually? And I don't have time to go into that, but that's for me and maybe for later. Do we have a part to play in providing some alternatives here? So to really summarise our response to arguments based on beneficence, it's generally well accepted that in virtually all cases, severe prolonged suffering can be substantially reduced by good palliative care. And remember that palliative care is holistic in its approach, catering to the physical, emotional, social and spiritual, if the person's open to that, dimensions of distress. We also need to be careful that the fear of suffering is against the reality, doesn't override all other ethical considerations. But this is such an important point that before I sort of move on to the last section, I want to touch once more on this whole question of unbearable pain at the end of life. Because it does worry people. I think it lies at the heart of the compassion argument and is something that we should not dismiss lightly. I'm going to call on some help here from Baroness of Llandaff. I don't speak Welsh, so I probably got that wrong. I don't normally like to put credentials up, partly out of time and partly because, oh, you know, wow, look who I found. But I think it's important in this case. I'm going to play a clip to get a sense that we are hearing from a well-qualified, credible person. She's been very much involved in palliative care for a long time, and in fact she, well, you can probably read it for yourselves. Okay, so this is from a slightly testy debate, as you will gather, but this is her take on this very difficult issue.
Let's get the mic back to you, because I just want to make sure. It was a really good question. I want to make sure.
I'm sorry, I don't think you've answered my question.
Take 10 more seconds and get right at it.
Hypothetically, you cannot alleviate the pain. No. I'm trying to understand your underlying argument, because this feels utilitarian.
Okay, don't argue with him, please. Just
I'm
make
sorry.
Make a question.
I would ask you to accept the hypothetical, but I can only ask.
Yeah. Well, I think your partner wants to take a crack at it also.
Can I answer it? Because you've asked a practical question. I've seen patients whose pain score was 11 out of 10, not just 10 out of 10. I have sat there with a syringe full of diamorphine and injected slowly, milligram by milligram, minute by minute, until their pain score is down and it is bearable, until we get it under control, and redoubled efforts. And sometimes the person has been a bit sleepy for a time, and we've had side effects and we've had to get over them. But my role as a doctor is to relieve that suffering. Those patients may say, I can't bear this, I ought to be dead. But that does not continue, that request does not continue when you get on top of their symptoms. I've had conversations with hundreds of patients about how they feel, about what's happening to them. Many people are devastated when they first realise that they have a life-threatening illness. The world is not as they thought it was going to be. But actually, when you work with them, and it is hard work, they come through and they often have a fulfilment that they never imagined they could have before. I've had people who've wanted, theoretically, to have assisted suicide or euthanasia, but they've abandoned that when they themselves are ill.
Okay,
but that's not the question. You've both evaded the question. The question asked you to accept the hypothesis that you can't relieve the excruciating pain. It's an attempt to understand your underlying philosophical or ethical position, and neither of you've both just evaded that question.
But no, because I don't accept... No, there's a fundamental premise here and a misunderstanding. Those of us that actually are the ones with the drugs and the techniques to relieve the pain keep on trying and going back and back and back again. So you're painting a hypothetical question. Yes, I'm saying I faced it practically, and I still oppose physician-assisted suicide.
So there you are. As I said, it was testy. It's a very emotive issue. But there's at least one point of view from a credible person that I think is worth noting. And I don't want to imply that that's the definitive word. Experts will continue to talk about and debate this, I'm sure, in the future. But in preparing for this talk, I do have to say, having read quite a lot of stuff over the last week, I really became actually more convinced that with good palliative care, we have no more need to be fearful about death and dying than any other of the trials and uncertainties that characterise human life generally. There's always risk of trial, pain, suffering, difficulty. None of us is immune from that throughout life. So to that extent, it seems to me that the fear about end of life, pain and suffering, should be no more pronounced than the normal sense of uncertainty that attaches to our lives generally. Okay, well, I've dealt at some length with the autonomy and beneficence arguments that represent really the mainstay of assisted suicide and euthanasia discussions. I want to round out my presentation with some arguments that sit within the broad rubric of both non-maleficence, doing no harm, and of justice, which in a modern democracy seeks to respect both the patient's own interests balanced against the relevant interests of others. First of three main points, assisted suicide and euthanasia are dangerous practices. Some of you who know me know that I like collecting book titles that say something. And there's a book it's 50 years ago this year that Ralph Nader's book was published, Unsafe at Any Speed. I'd like to commandeer that title if I was writing a book on this subject. Assisted suicide and euthanasia, unsafe at any speed. If I walked down Lambton Quay and asked people to envisage a situation where they thought that assisted suicide might be justified, it's interesting just to ponder on what they'd say. They'd probably talk about an adult, middle-aged or a bit older, maybe elderly, perhaps in the last stage of a terminal illness, perhaps in severe pain, that might be mentioned, and wanting basically to end it all, kind of having a sense of hopelessness and nothing more to live for. But we know from both the US and European experience, and I've kind of touched on this a little bit already, that not only are most people requesting assisted suicide or euthanasia are not in physical pain, but a lot of people have been killed in circumstances that are very different. And I just gave you an illustration of 2 or 3 of those from the Benelux countries. Once we see the principle of state-sanctioned killing, that it really does become impossible to contain over the longer term. It's a bit like the genie out of the bottle, I think. It's not an unfair analogy. I know this is arguable. People would push back on this, but that's my own view on this. The Netherlands and Belgium have illustrated how that slowly but surely the criteria get broadened. Suffering under the Dutch legislation has effectively been redefined to include ageing, bereavement and loneliness over 14 years. And as I mentioned, it's expected that it may become something of right. I don't think this will happen immediately, but it could happen within the next 5 to 10 years for people who are aged over 70, essentially a citizen right. Professor Theo Boer, an Utrecht University academic, has been a member since 2005 of a review committee charged with monitoring euthanasia deaths, and he's reviewed over 4,000 cases in Holland. This is just his view, I know, but he admits that he was wrong, terribly wrong, in fact, he said, to have believed that regulated euthanasia would work. I used to be a supporter of the law, he said, but now with 12 years of experience, I take a very different view. He probably had in mind a number of things, the accepted fact that in Holland and Belgium, a number of cases of euthanasia go unreported, which is accepted officially, by the way. I don't quite know how that works, but they just go unreported. Some deaths are now without consent or an express desire for it. It's controversial, which involves patients with dementia and severe depression. And as noted earlier, the criteria for eligibility have become increasingly broadened over time. I think there are also practical difficulties around enforcement. This is a complicated area as well, and I don't have time to go into it in detail. But I have mentioned what strikes me as an outsider as a very benign attitude towards reporting in the Benelux, but also in Oregon. I was shocked to discover, I don't know if this surprises you, that no healthcare provider was present at the time of death for half of all the assisted suicides in Oregon. How do we really know what happened? We don't, because sometimes, as I said, death can have occurred even years later following when the medication was issued. So I just shake my head at the enforcement implications. Number 2, we should act to avoid harm. Thinking about the implications of assisted suicide and euthanasia, people have identified a number of likely harms that will result. Some I've touched on already, but just to list them quickly. Harm to the medical profession and the doctor-patient relationship from participation in the killing of patients, trust, integrity, respect, all of those things. And this is in part why the NZEMA and the World Medical Association are so opposed. There's the question of mixed messages to those who are depressed, including vulnerable teenagers and others contemplating suicide. There's harm to vulnerable, ill and elderly people who may feel the pressure to end their lives early. And this is where I start to get personally quite concerned. This is for me quite a compelling argument. And it takes 2 forms, actually. The first one, the pressure that subtly shifts the right to die to a duty to die because of feeling a burden or whatever, like that. Baroness, lots of baronesses tonight, Baroness Tani Gray-Thompson, love the name, from Wales, expresses the concern better than I can, and so we will play a clip of Tani. I haven't put all her credentials up, but I was impressed by the fact that she's won 11 gold medals at the Paralympic Games. That counted for something with me. And she sits in the House of Lords as an independent crossbench peer. So there you are, this is Tani.
I'm very worried that a right to die which I don't believe we have actually, it becomes a duty to die, because you can't take this in isolation. If you look at other jurisdictions in Washington state, 61% of people have said they've chosen assisted suicide because they feel a burden to their family. Actually, pain is way down the list. And also, I think if we go down this route, we stop talking about good palliative care. We actually don't talk about end of life. We don't talk about death enough in this country. But actually, I think it's too easy to become an issue about cost, that someone's life is too costly to carry on, so you're doing your duty, you know, for your family, for your relatives, for the NHS, for British society. And I think that's a really dangerous path to go down. When you look at individual cases of people who are in pain, it's heartbreaking, and I wouldn't wish that on anybody. I still think we need to come back and look at their proper care, and I think we need to make sure that we protect people. Very sadly, what we're being asked to do is not about making laws for individuals, it's about making law for the whole of society and about protecting public safety. And that, for me, is why I don't support assisted suicide, because I don't think we can protect the vast majority of the public.
Okay, so there's Baroness Tarney. So I mentioned two forms, this thought of pressure to end their lives, this idea of morphing from right to die to a duty to die, but also pressure from family or trusted friends for ulterior motives. Now, of course, critics, I've heard this come up before in debate, and critics are quite dismissive of this. They immediately go back to the safeguards discussion, and we can't entirely dismiss that. But, you know, I have to say that despite all of that, I remain completely unreassured, if there's such a word. And I'm not a cynic, but I've personally seen, a little bit older, personally seen and heard about too many instances where family or trusted friends have been very self-seeking in their dealings with elderly relatives. I'm sorry to say, but it happens. And what safeguards do we have against these? I'm not sure that we would ever have adequate safeguards in that respect. So to summarise these various points, and I'm getting towards the end, I'd like to play a clip from Philip Blond, a British political philosopher and theologian with a certain notoriety. But I liked what he had to say. So again, it's a debate setting, and I've just taken the clip out of Philip making his piece. But I thought it was a nice way of gathering up a number of these points before I make my final closing remarks.
This is all very worrying, and I think the question rightly raises how it changes the relationship between a doctor and a patient. Look, I think this is entering very dangerous waters, and we appear to be doing so in a way that we're not really aware of. What this creates, what voluntary euthanasia creates, is a class of persons for whom there will be a cultural force to say, yes, I want to end my life. Because as you approach the end of a certain stage of health, you begin to feel more and more acutely vulnerable. And actually, if you approach the certain conditions, which is how legally it would have to be constructed, where it would be permissible for a doctor to euthanize you, your relationship with the doctor will change, because the doctor will be forced to tell you, actually, euthanasia is an option. And then you will start to feel the social pressure of, oh, I'm a burden on the state, I'm a burden on my family, oh, my children, look at how I'm suffering, it would be easier for me if I just killed myself. And the thing is, as people get older and more vulnerable, they get also incredibly polite. And the fear I have is people will actually start to feel morally they ought to kill themselves in order that other people are improved by it. And I think this gets everything wrong about human life. It gets our relationship to those who are suffering wrong, it gets the status of suffering wrong, and it actually starts to create a society in which the moment we owe something to somebody, then in some sense we should self-terminate. This is not a good society. This is not a decent society. Actually, it's vaguely horrific and genuinely frightening. Now, I do accept there are marginal cases, and I think your accounts are very apt and real, and there is a genuine sense. My own grandmother died of Alzheimer's in really a very awful way. But what was interesting is she still had consciousness that was valuable and was morally important for all of her family. And actually it was very important for my mother and for our family over that very long process of dying. It brought us closer together. It was morally worthwhile for me. So the idea that people, even when they're in trouble, aren't sources of moral teaching for you, it's just profoundly wrong.
Okay.
And it's not a good society that does
I want to hear
that.
from
Nice summation, I thought, of a good point of view. Okay, well, my final point to finish might seem an odd one, but as I've thought more and more about this issue, this is probably the one that worries me most, strange as it may sound. Legalised assisted suicide and euthanasia requires everyone to make a choice. You know, so, well, that's obvious, isn't it? That's the nature of what it is. But as I've thought about it, at first blush, so-called end-of-life choice sort of seems straightforward, doesn't it? Like, if I reach a point where life seems hopeless and unbearable, then I have the option to choose an assisted death. Otherwise, everything's sweet. Life goes on. It's not there. But I don't think it's that straightforward, and it was alluded to a little bit here in the comment we had from Philip. The choice lurks in the background all the time, particularly for those where life circumstances have become harder through serious illness, maybe just the ailments of old age, depression, or whatever it may be. You add to that some feelings of loneliness or being a burden in some way, plus some quiet remarks or innuendos from a family member or friend, shake and stir, you have a recipe for someone who starts to ask themselves that question potentially every day. Imagine waking up every day with that question slightly there. Perhaps several times a day. And it's not a one-off question. Oh, yeah, I've dealt with the question, done and dusted, I'm not going to go there. The question sits, you know, a little bit like a monkey on a shoulder. And it whispers. Now, this, of course, won't apply to everyone. Maybe the majority. You know, people tend to be pretty strong-minded for the most part. But I worry about the fact that that could well happen in more instances than we might ever realise. I just wanted to finish with talking a little bit about my dad, because I think the personal touch, you know, helps. It's helped me. Crez had a very severe stroke, almost sufficient to kill him, actually, in 2002, but not quite. So it resulted in him being paralysed on one side of his body, unable to speak, read or write. He had global aphasia, if that means anything to you, which meant that messages coming in and out were kind of scrambled a bit, you know. So he couldn't speak, as I said. Yet there he was, particularly for the first 7 years, by and large pretty much there cognitively. He got a bit tired sometimes, but he was pretty much there. And so the last 8 years or so of his life was spent in this condition, basically completely dependent upon others. So although he couldn't speak, such was his distress in the early days, he could manage one word, just one word. Sorry, this is a bit emotional. He would say sorry. You know, he'd go and see him and he'd say sorry. And it was clear what he was conveying. He was sorry for what he perceived his situation to be. Sorry for his effects on his family. And so they were emotional times for myself and sister and Damaris and all of the family, really. And it was hugely significant at the time. But after about a year, interestingly, he stopped saying that word, actually. And I feel, Damaris and I actually feel to this day, it was because that particular sense of sorrow had abated, and he came to a certain place of acceptance of his lot, maybe a sense of relief at the family's commitment and so on. So although over time his global aphasia didn't change, we kind of learnt to bring the world to him. How to visit in the best sense of the world, how to converse, swap notes. We had ways of communicating even though he couldn't speak, which were surprisingly effective. And so with a bit of perseverance and energy and so on, we all really learnt. And, you know, I look back and I genuinely feel that for the most part was a good time for Mum and Dad, actually. We had our moments, we had our bad days, who doesn't? But they were good times, and there was a certain mellowness, peacefulness, contentment that was evident in Dad, and we laughed a bit, and we did things together in his somewhat limited world. So what's the point I'm making? It's not at all to say that, you know, we did a terrific job or anything like that, but rather that in the midst of trial and tough times, we were able to come through that to a good season. And one or two others actually have talked about this on the clip. I've got other examples that I don't have time to show. But my point is, had there been an option, I mean, Dad was of strong Christian persuasion. I don't think he would have. But I think of other dads Well, you know, maybe they aren't a person of faith. They've lived a good life. You might say they're a good person. But they reach a certain window where they say, oh, it's hopeless. You know? And in fact, I don't have time to show it, so I won't. But Baroness Finlay, her mother, at the age of 84, was very seriously ill with breast cancer. And she said, her mother said, look, if I had an option to have assisted suicide now, I would take it. To cut a long story short, she actually lived for another 4 years and reflected very positively on the time that she had. So, you know, there are times, there are seasons, there are ups and downs. But if that's terminated, in a sense, artificially, and that's really what assisted suicide and euthanasia is, then think of all that's lost. And related to this point, just to finish, I said the question, the choice always sits there. But also, if the choice exists and someone is approaching the end of life, what are the conversations going to be about? For family, for the person and so on. You know, I can just see it. Everyone will be fixated on the question. Shall I stay or shall I go? You know, as the song says. And I don't say that to be funny. I think that question just sits there. And rather than saying, it's not an option, let's get on and do the best we can with life while we have it. And to me, that's a marked shift in the sort of conversations that could well happen if we had a law change.